sphenoid os. So sphenoid os sometimes can be evident like this, but many times it will be covered by a membrane. So if you don't see the sphenoid os directly, what you can probably do is you would probably roughly get an assessment of the position of the sphenoid os by keeping the coina as a reference point. So you have so there you can see that is the eustachian tube and this is the, so that should be around 1.2 to 1.5 centimeters, somewhere in that distance. If you stay close to the septum in the midline above the coina, you could probably get directly into the sphenoid ostium. So even if it's covered by a membrane, that is the way you get into the sphenoid ostium. Now, to take you to the anatomy here, coming back to the lateral wall, so you see the uncinate, you can see the attachment of the uncinate here. This is what we describe as the maxillary line. Can you appreciate that? The easiest way to identify that is to probably pass a probe here. You can that firm feel when I run through this bone, and subsequently you can see that it just dips in. Can you see that movement? So that will be the line of attachment. So this is how you can demarcate the line of attachment. And in this case, you also have an accessory opening in the fontanelle. So this is an accessory opening in the anterior fontanelle. So this is a vertical portion, and subsequently you have the horizontal portion here as well. Okay. So that is the inferior turbinate. And again for anatomy, if you see, this is the posterior edge of the uncinate, and this space between the bulla, anterior face of the bulla and the posterior edge of the uncinate is what we refer to as the hiatus sigmoidalis. And if you follow this middle turbinate, now you can see this middle turbinate transverses as it goes posteriorly with the chondral. Can you appreciate? This is basically the ground lamella or your basal lamella, and this space that is there between this bulla and the ground lamella is the retrobullar space. Okay, fine. So this demarcates the anterior ethmoid cells from the posterior ethmoidal cells. So what is anterior to the ground lamella is all the anterior ethmoidal cell, and what is posterior to that is the posterior ethmoidal cell. Am I clear with that? So this is the axilla of the turbinate. So this is all your basic anatomy. Now, in the morning sir had demonstrated how you do it with the backbiter. So that is probably the most commonly used technique. Okay, so you engage a backbiter, open it, get behind the uncinate, hook it, bite it, make a cut somewhere at this junction between the vertical and the horizontal, the transition between the vertical and the horizontal. The other options that you have are you can probably use a single knife, you can use a this is an elevator. So what I am doing here is I have already demarcated the line of attachment of the uncinate. So I am using an elevator. And once I open up with this elevator, you are basically opening into this three-dimensional space, which is basically your infundibulum, and subsequently you get to look into the maxillary sinus. Is that clear?
Yes.
So you have the hiatus cellularis, you have the hiatus here. It connects into this three-dimensional space that is the infundibulum, and then you have the maxillary opening. So what I have separated so far is just the vertical portion of the uncinate. Can you appreciate that? The horizontal portion is still left intact. Is the picture clear? And now what you are seeing through this is actually the bulla. Can you appreciate the bulla in there? From this side as well. Okay. Now at this point, now if you are not using a conventional, if you are using a conventional instrument, the options that you have are to use true cut forceps, which gives you more precise cuts so you can avoid the mucosal tags. Now unfortunately I don't have a true cut, so I'm just using a scissors here. You could make cuts superiorly, you could make cuts inferiorly, and then you could take out this entire superior portion of the uncinate as a single piece. Okay, forceps. In fact, sir did show you the technique of trying to preserve the mucosa of the uncinate, but I generally don't do that. There is something inside this. This is what I was talking about. It tends to strip. So use straight cuts. This is the conventional turbinate scissor, not the small scissors. So just excuse me and just, yeah. Is that fine? Okay. So we have the view of the, let's push this mucosa back in our out of us. And now what we have is, we have the bulla, you have the maxillary sinus, but still there is this horizontal portion. So to say that your uncinectomy is complete, you need to dissect out this horizontal portion of the uncinate as well. Can I have a second? So it's equally important to remove one of the reasons for restenosis. So you can piece out this bone here. You can take out the mucosa and subsequently you can see the horizontal portion of the uncinate. Can you appreciate that? Yes? So all this bone has to go out. Okay. Only then you can say that your uncinectomy is complete. So once you take out this bone, so I am not using the right instruments here. Yes. So you can see there is a horizontal portion of the uncinate which we take out. Fine. Okay, that is gone. And subsequently, you can let both these layers of the mucosa approximate. You can debride it so that there is no bone and that remains patent. Now, when you look up, at this particular point,